Welcome to AETCM, the emergency medicine channel. Today we are going to discuss about a patient who presented to ER with weakness of all four limbs, acute onset. A 72-year-old female presented to ER with complaints of weakness of all four limbs since last 2 days. Initial 10-second assessment, patient was conscious, oriented and obeying commands. Primary survey, her airway was patent. There was no pooling of secretions or gurgling. Breathing, she was not tachypneic. Her respiratory rate was 14 per minute and her respiratory efforts was good. Saturation was 98% in room air and air entry was bilaterally equal. Circulation, her heart rate was 82 per minute and blood pressure was 130 over 90 millimeters of mercury and all peripheral pulses were felt equally and bilaterally. Disability, her GCS was E4, V5, M6 and pupils were 2.5 millimeter reactive to light. And I asked for any pain, pain score was 0. Exposure, her temperature was 98 degree Fahrenheit and GRBS was 140 and hypothermia was prevented by blanket. So, since she presented with a history of all four limb weakness, we don't know what is the cause. So, I took an ABG to look for any PCO2 retention or anything else there for, if at all, diaphragm involvement.
No, this is the first attack.
Sorry.
It's the first attack.
First attack. So her pH was 7.381, PCO2 was 34.4 and bicarbonate was 18.8. It was a metabolic acidosis with a chloride of 109. So it was a normal anion gap metabolic acidosis, hyperchloremic, maybe because of the normal saline given from outside.
Okay.
And in our ABG we will be able to see the sodium and potassium. So sodium was 138 and potassium was only 1.3.
Okay.
So I immediately took an ECG.
If a patient is having a sudden onset of weakness, what are the differential diagnoses you suspect?
Sudden onset weakness, it can be hypokalemic periodic paralysis can be there.
Okay.
Then because of a crate bite, patient is
snake
not
bite,
snake bite is there. Then a GBS.
GBS, progressive
weakness
okay.
from lower limb to upper limb.
Any trauma you want to ask? Trauma history?
Yes.
What trauma history you want to ask?
C-spine injury will be there. Then any compressive neuropathy, that will be gradual only. That one.
Can compressive myelopathy present with acutely? Like compressive intramedullary compressions or extramedullary compression can deteriorate acutely?
Because of the edema.
Because of the bleed into a tumor can present with acute or hematomyelia, that also present acutely. Or anterior spinal artery thrombosis, they also present acutely. Vascular lesions and bleed can produce acute weakness. Otherwise, chronic compressive myelopathy rarely produces acute weakness.
And tick paralysis.
Tick paralysis produces relatively acute weakness.
So ECG was taken, sir. ECG standardization was normal, rate was 76 per minute and regular in rhythm, normal axis. P wave was normal for this patient, PR of 163 and QRS complex was normal but QTC was prolonged for 592 and there was ST depressions in all the leads and there was absent T wave and U waves from V2 to V3, U waves were there. So there are
present or absent?
Present, sir. So there are features of hypokalemia in the ECG. Moving on to the ample history, sir. Since there is evidence of hypokalemia.
So you have a patient who is having hypokalemia, but your ABG shows acidosis. What are the differential diagnoses? You told it is due to fluid given from that hospital. Otherwise, what may be the differential diagnosis?
Yes, sir. So, if there is, usually we will be expecting metabolic alkalosis. If there is metabolic acidosis, it can be either because of the renal loss which is causing the metabolic acidosis, like renal tubular acidosis.
Okay. The most important is renal tubular acidosis. But if the patient is having CLD? So CLD itself can produce acidosis or lactic acidosis can produce acidosis. In that patient, hypokalemia is one of the cause for acute weakness and they can have altered behavior, exacerbation of hepatic encephalopathy. All these things can occur. Can alkalosis produce hypokalemia?
Yes, sir. Usually alkalosis is associated with hypokalemia.
So alkalosis itself can produce hypokalemia. Hypokalemia can produce alkalosis. Both are possible.
Then if it is non-renal cause of metabolic acidosis with hypokalemia, it can be because of diarrhea and GI loss.
GI loss. But the patient does not
have. So that time we have placed 2 large bore IV cannula. One was an EGV was placed, and we started her on 40 milliequivalents KCL was started with 500 ml of NS. Over 5 hours we have started, and we have placed a periphery. Through that we started 20 milliequivalents KCL correction started. Then we went ahead with the ample history. There was no allergies. She's not taking any medications like beta agonists, any insulins, Lasix, amphotericin B, or terbutaline. These tablets she was not taking. There is some past history of BP, PV, and some that was the only history, and she was already treated for that. Last meal was 8 hours back. Events was patient gives a history of heavy carbohydrate meal 2 days back at night. Next day morning when she got up, she was feeling weakness of the all 4 limbs. So all were affected together, and weakness was more proximal than distal, but she was able to move her toes and fingers. There was no bowel or bladder removal. There was no constipation or urine retention. There is no history of any trauma, any seizures, any breathing difficulty, any unknown bite, any history of any medication intake or anything. She was taken to outside hospital and found to have a potassium of 1.3, and there they corrected her with normal saline and 40 milliequivalents of KCA. But in view of persistent weakness, she was referred here. Moving on to the systemic examination, her power in the upper limb power was 2/5 and lower limb power was 1/5. It was flaccid only, and weakness was more proximal than distal, and reflexes were bilaterally reduced. And sensation were normal.
All myopathies, weakness is predominantly proximal. Most of the myopathies it is proximal. Only one myopathy you have distal weakness. What is that myopathy? It's inclusion body myopathy. It is not very common, but there you get distal weakness. Almost all myopathies are proximal. Neuropathies are mostly distal. Okay.
Then in the other system examination, in the abdomen was soft, non-tender, and bowel sounds were present. And cardiovascular system examination was within normal limit, and respiratory system examination was within normal limits. So we have a patient with hypokalemia with weakness of all 4 limbs, and ECG changes are also there. So we wanted to work upon that. So we immediately sent for a urine sample for urine potassium, which was only 6. So it is
low, less than 20 milliequivalents.
So we can rule out the renal causes of hypokalemia. So that was ruled out. Then we asked for, as such, history-wise, there is no vomiting or GA loss history, any other nasogastric aspiration, diarrhea history was not there. So it can be because of the redistribution. So there is no other medication history as such, and magnesium level was also normal. So and since there is a history of heavy carbohydrate diet, it might be because of the hypokalemic period.
Magnesium hypomagnesemia is associated which type of hypokalemia?
Redistribution.
It is mostly associated with renal loss. Because potassium always go with magnesium through the kidneys. So when there is a hypokalemia due to renal loss, that may be mostly associated with hypomagnesemia, and that hypomagnesemia itself promotes the renal loss of potassium.
So this patient, mostly it will be a redistribution because of the heavy carbohydrate diet, sir. So we have started after giving 60 milliequivalents KCL, we repeated that.
So before that you should know how much deficit is there. So this patient is 1.5 is the potassium, normally is 3.5. So 2 milliequivalent difference is there from the normal value. So how much deficit is there?
Almost 600 milliequivalents deficit.
For 1 milliequivalent, it is equal to 300, nearly 300 deficit, and this is 2. So 600 deficit is there, and daily requirement is?
Daily 60 milliequivalents.
1 milliequivalent per kg. So around 60 milliequivalent. So this patient requires 660 milliequivalents. How do you correct it?
Since this patient can eat, we have to give dietary correction with
the dietary correction is not first choice here. This patient has got an ECG change. So we need to correct fast. Okay, dietary correction is only done where the patient is absolutely normal. There is no muscle weakness. There is no ECG change. Here ECG change is there. What is the problem of long QT in this patient?
Arrhythmias.
That patient can anytime develop arrhythmia. So we have no time. We have to act fast.
So for her, a central line was placed, and
Okay.
we have started correction with KCL correction was started. So,
Okay.
along with that, for supplementing the daily requirement, we have
So
started.
how do you give IV through central line? How much you can correct?
Sir, we can dilution we can change since we are having a central line, but we can correct only maximum 20 to 40, 10 to 20 milliequivalents per hour we can correct.
Okay, so you can only correct 240 milliequivalents in a day, maximum. That's all. You acutely you can correct some amount, then but like 24 hours the correction cannot be more than 240 milliequivalents, so that should be corrected.
And along with that, since she is able to eat food, we can give fruits and KCL syrup. KCL can be given. Can tender coconut water can also be given. So if
which fruit contains maximum potassium?
Papaya, banana,
lemon. Okay.
Then spinach and some smashed potatoes will be having these. So if we are giving 15 milliequivalents KCL, 15 milliequivalents will contain 20. 15 ml will contain 20 milliequivalents. So if we are giving thrice dose or TID dose, it will correct 60 milliequivalents. So that was corrected, sir. And as her potassium was improving, her weakness also improved, and she was able to mobilize her.
Okay.
So today her potassium level is 4.3, and she is able to walk.
So how much you have given for this patient?
This patient we have given total we have given almost around 400 milliliters.
So why it has become on the opposite side? It has become more. What is the reason for that? You should be very careful when you are correcting hyperkalemia due to shift. Okay, this can, once the carbohydrate levels come down in your cells, this can reshift back to the blood vessel. So when we are correcting, even when we are telling it, patient requires 600 milliequivalents, that is only needed when there is a renal loss. But in a shift hypokalemia, you cannot give that much potassium, because sometimes it can go to the opposite side, and hyperkalemia and its complications can occur. So you should be very careful. So the book says that it is 600 milliequivalents are deficit. But this patient is already having that much potassium inside the body or inside the cells. It can shift back once the glucose comes down.
So basically, if we are getting a patient with hypokalemia, first we will have to send for the urine potassium, and if the urine potassium
first is always ABG. So you see acidosis or alkalosis. Alkalosis is mostly common. Acidosis is there. You have to have some other finding, like you have to look for some other diagnosis like renal tubular acidosis. Okay.
Other causes, non-renal causes.
Okay.
And urine potassium of more than 20, it will be renal loss, and less than 20 means non-renal loss, or because of depletion and reduced intake, or it can be because of redistribution. And if there is associated metabolic alkalosis, and if the urine potassium is more than 20, we will have to look whether this patient is having hypertension or not.
If there is hypertension,
then we will have to send for the renin
angiotensin level and okay.
So, and if that is high, it can be because of the renin secreting tumors. If not,
or renal artery stenosis, renin secreting tumors, hyperaldosteronism, like that we have to think. Okay.
Otherwise, it can be because of some Gitelman syndrome.
It all occurs in younger age group of patient, Gitelman's, Barter's, all these things.
Then drugs as such, if it is not getting corrected, we can give spironolactone can be given. So 25.
What is the action of spironolactone?
It is a potassium sparing diuretic. So it will prevent the loss of potassium.
Okay. Renal loss of potassium is bad.
And if it is if there is associated gynecomastia and complication, we can give eplerenone, same dose, it's a 25 to 50 OD to BD dose.
Okay. What happened to this patient afterwards?
This patient's potassium improved to 4.3, and she is able to mobilize. There was no constipation or anything. And initially, she in the ICU she had some urine retention, but that also got subsided. Now she is able to pass.
How long it take for the patient to come back to normal? Muscle tone?
36 hours.
36 hours. So suppose this patient is coming with some respiratory insufficiency. See, pertaining to the age and other factors, how will you plan for an intubation?
So, because of hypokalemia, there can be respiratory muscle fatigue. These things can be there, and PCO2 retention can be there. In such cases, we might require a RSA. So, respiratory excursions will be low for this patient. So, supplementary breaths should be given. And if at all we are planning for induction paralysis and all, we don't have to give the full dose. Only lower doses is required because
for that airway assessment. 74 years.
Yes.
What all things do you anticipate? What will you look for?
Loose tooth will be there.
Loose tooth.
Artificial dentures.
Denture seed into this patient. The mask fit, we cannot able to hold it properly. If it's artificial denture, complete denture, we can ask the patient to keep it till mouth till you are completing the mask ventilation. When you are intubating, you can remove it.
This patient might be constipated, so there is high risk for aspiration also
Ileus.
while ambling.
Hypokalemia because ileus for the distended abdomen. In case necessary, pre-hand we can put a right strip also.
Then the medication dose can be reduced.
Pre-oxygenation. Then the medication selection.
Selection wise, we can use all medicines, sir, but in a lower dose. There is no contraindication.
Age-related as well as muscle weakness is there. Then we can reduce the dosage of all drugs. Regarding muscle relaxation,
both depolarizing and non-depolarizing.
maximum we try to avoid saxamethasone. So you go for the non-depolarizing, short-acting drugs. Do not use the lower dosage. Any other thing?
If the patient is already intubated and all, nebulizations and all, we should be very careful because that itself can again cause shift hypokalemia.
Yeah, and nebulization with what?
Beta 2.
Any agent. So whichever one is the temperature maintenance. What is the effect of hypothermia?
Hypothermia can again
So we have
reduce.
to prevent hypothermia. Throughout we have to keep, whether it's the ICU patient or in your setup, we have to take care of the normal temperature is the best policy. Then acid-base status.
Acid-base status, if you are aspirating the nasogastric tube, that
You
all
try to avoid alkalosis. Further, this one you better to avoid alkalosis.
alcohol.
So when you are ventilating, don't hyperventilate. Okay. Then other drugs, so not potassium sparing diuretics. You can avoid. Any other thing? Suppose certain
Glycemic
conditions,
control.
diuretic is indicated. But you can't
Potassium
use it.
sparing diuretics can be used. And glycemic control also should be.
Glycemic, more important thing is glycemic control, and all things should be done under the ECG monitor. Continuous ECG monitor and periodic potassium level assessment should be done.
Salt intake.
Salt intake.
What is the action of salt? Excess salt in potassium excretion. Excess salt intake can increase the potassium excretion. So we should be very careful in ICU patient. Even if it is not renal loss, we have to give low salt diet so that renin, angiotensin, aldosterone axis will be reduced. So that some amount of potassium can be further retained. Okay. Now what advice you give to this patient? Because the second time this patient is getting, this patient can have channelopathy. What is channelopathy?
Potassium, E-sodium.
So muscle has got a channel, potassium, sodium, potassium pumping channel is there. Because of that problem in the channel, patient can have hypokalemic paralysis, hyperkalemic paralysis. So many things can happen. So one of the channelopathy is hypokalemic periodic paralysis. So what are things you advise to the patient?
Avoid high carbohydrate diet.
Very important thing is high carbohydrate diet should be avoided, or patient should be taken with like low amount of high carbohydrate diet. Then any investigation you want to do? Any other test other than potassium testing? Thyroid function test. Many patients who is having Graves' disease, hyperthyroidism, can have hypokalemic periodic paralysis or both hyperkalemic periodic paralysis. Okay. What happened to the patient afterwards?
She improved, sir. We are planning to discharge her tomorrow.
Okay.
Thyroid functions are
So it's normal. Anything else, sir? Okay. Thank you.